We have some evidence, more evidence at this meeting, and we happen to be blessed today with the lead author of some of the studies that are being presented here at the meeting of looking at, optimum frontline choices. And I'll let Johanna describe those studies and kind of walk us through them. But they also bring into play what I always like to call the kitchen sink versus the bathroom sink of a three-drug regimen of FOLFIRI, FOLFOX regimen. So take it away. Tell us about these studies and how you interpret their impact on our practice today.
Well, at least you didn't say toilet, right? You said bathroom sink. So two big studies looking at chemotherapy backbones. And I'm going to go the first one with the MAVERICC study because this is just what we've been talking about. OX versus IRI, which do you pick? And so this is a study that looked at FOLFOX plus bevacizumab versus FOLFIRI plus bevacizumab. It's almost 400 patient study, primary endpoint progression-free survival. And very interestingly, what they're reporting out is the progression-free survival in their irinotecan treated patients seems to be longer than the oxaliplatin treated patients. Tony's over there like, yeah,
told you so. Is
told
this
you.
the told you so?
Told you so. Yeah. And when you look at the survival data, it seems to maybe be bordering a little bit more impressive towards the FOLFIRI side. Now, what happened? When you look at the intensity of the dosing of the regimens, you can see very clearly that the folks who got oxaliplatin got 6 less cycles of chemotherapy with oxaliplatin than the irinotecan. So this is also alluding to Tony's point of the issue where toxicity plays a part in how people do and what their choices are and when you drop a treatment versus not drop a treatment.
In that study, I don't know, does anybody remember, was there a sort of forced maintenance?
No.
Or you could do whatever you wanted?
Right, and so that's the rub, is that if you had a forced maintenance, would you see something a little bit different? I also think with the maintenance approaches, it really points out that very often with the oxaliplatin-based therapies, nobody goes back to the oxaliplatin again, or until much later. And so how does that play a role? And do we really need to squeeze the juice totally out of the lemon to say that they got all of that therapy? So I think the MAVERICC study is saying, well, is FOLFIRI something that we should be considering as first line because people stay on it longer and are able to get that dosing that'll take them until progression.
Yeah, so, go ahead, John.
I think this is really interesting because, several of us remember a decade ago when this debate was going on, which chemotherapy is a better partner for biologics, and a bunch of us were involved in the Bekaii-Saab study when there were a variety of studies going on, and at that time, FOLFIRI and Bev offered the longest survival of any of the combinations across trials. I think many people sort of ignored that, but it's interesting to hear that in a head-to-head comparison, maybe it is better.
I did not ignore it. But I agree, and actually if you look at CLGB 80405, although there were somewhat different patient populations, and again, not that there were these comparisons between the FOLFIRI and FOLFOX group, but that is very consistent with Johanna's study and with the Bekaii-Saab. You continue to see that slight trend, and again, it's not a 4 or 5 month difference. It's a small, but I think meaningful difference for those patients with metastatic colorectal cancer.
I sort of interpret this as if you keep your foot on the pedal longer, you have better, longer control. But I could also imagine you get a tireder patient, a little bit more bone marrow, all those things, but you then say OS looks a little better too, which means they're getting subsequent lines of therapy, so they're okay to do this. Well, sorry.
Just remember with FOLFOX, it's not just the lingering neurotoxicity that can limit sometimes access to second line, but it's also in 5% of the patients grade 3 plus thrombocytopenia because of hypersplenism, which also limits access to other trials or other regimens or intense other regimens. So there are certain nuances on the long term that may affect not just the progression-free, but the overall survival as well.
Very good. Well, let's go to the second study then, kitchen versus bathroom sink.
Right, so the toilet, no.
Actually, we have two different sinks. We have bedroom sink. Anyway,
does the husband have a sink? Does the wife have a sink? So what this did was playing off the TRIBE study. So the TRIBE study was a study that looked, it was an Italian study that looked at FOLFOXIRI. Now this is not FOLFIRINOX, right? Because FOLFIRINOX we're used to giving for pancreatic cancer patients now. But FOLFOXIRI, it's a different regimen where you use a little higher dose of the infusional 5-FU, a little lower dose of the irinotecan. So this was FOLFOXIRI plus bevacizumab.
Do you think that matters?
I don't know.
Do you think it matters? What recipe you use and the soup, or
You know, the
minor
lower dose of
pause.
irinotecan probably
Easier.
it makes it easier.
I reduce it just whichever recipe. I always come down to 150 is what I tend to start with.
And sometimes even 120.
What do you do?
So I actually give full dose
You're-
FOLFOXIRI, but
you're
not
tough.
FOLFIRINOX.
I see. Okay.
Yeah.
Richard?
Same thing, I dose to reduce irinotecan 150.
Bolus 5FU? Anybody?
No.
I take
Dropped?
I delete it.
Dropped?
I take.
Now it's not in FOLFOXIRI.
Right.
Yeah.
But so it's not there in the first
And I
place.
don't do
I take it out.
FOLFIRINOX.
And drop it.
Yeah.
Okay. So I think we're all modifying
leucovorin.
that comfortable
And
regimen.
the leucovorin.
And you drop
If
the
you're not going to
leucovorin.
give bolus 5FU, I wouldn't give leucovorin.
A debated point.
I still give leucovorin.
I do too.
When you have
I have stock in
infusional-
the company. No, I'm
So-
teasing. I
So
don't.
when you have infusion, well, that's not a stock, that's worth money. But anyway, so
This is my portfolio. What do you think I'm
that's
on
why
the
you're not
show right
retiring
now?
anytime soon. But infusional 5FU, that goes over 2 days, and you're giving leucovorin just for a fraction of the time, you know,
Yeah.
is really questionable. But anyways, it's not wrong to give it.